Welcome back to the Deep Dive.
Great to be here.
Today, we are tackling something that is incredibly specific, yet for the people living with it, it's the filter through which they experience their entire lives.
Yeah, that's a good way to put it.
We're looking at a condition that is often misunderstood, frequently misdiagnosed, and causes a tremendous amount of not just physical pain, but deep, entrenched psychological distress.
We are talking about lipedema.
Exactly. And we aren't just skimming a WebMD article today. We're doing a sort of a forensic analysis of a very specific text.
Lipedema, a practical guidebook from 2022.
That's the one.
And it is a fascinating and, I have to say, a somewhat heavy topic.
Heavy is the right word.
Heavy because of the human suffering involved, but fascinating because the biology is so incredibly complex.
Right. And you're right. The source material really matters here. This is not a blog post.
No, it's a substantial medical text edited by Zahar Jandali, Lucian P. Giga, and Corrado Campisi, a real powerhouse group.
And just to set the stage for you listening, this is a translation from a German edition.
Mm-hmm.
And having read through it, you can feel that rigor. It's structured, it's precise, but it also has this very specific mission.
Yes.
It almost feels like the authors are trying to intervene in a crisis.
That is exactly the vibe.
Yes.
It's written by these high-level surgeons, but it's explicitly designed to bridge the gap between, complex science and the patient.
A communication breakdown.
They're trying to solve a communication breakdown, and honestly, looking at the preface, that breakdown sounds more like a canyon.
Well, let's start right there, the preface.
Okay.
Usually, medical textbooks start with, a definition or a history lesson.
Right, the dry stuff.
These authors start with the patient experience. They use this phrase that really stuck with me, the adventurous search.
It's a striking choice of words, isn't it? Adventurous search.
It is. It sounds almost romantic until you read the context.
Oh, it's not romantic at all. They aren't talking about a fun adventure. They are describing a desperate, winding journey.
A journey for answers.
Exactly. They identify the core conflict immediately. Women suffering from painful disproportional tissue distribution.
That phrase alone, painful disproportional tissue distribution, it does so much work.
It really does.
It's not just weight gain, is it?
No, and that is the critical distinction. Disproportional means the body isn't growing evenly. You might have a narrow waist, a narrow upper body, but the legs are expanding uncontrollably.
And painful.
And painful is the other key. Regular fat tissue, it doesn't usually hurt when you touch it. Lipedema tissue does.
So the authors are highlighting that the patient usually knows something is biologically wrong, like long before a doctor ever confirms it.
That is the adventurous search part, that gap between I know my body is wrong and a doctor finally saying, yes, this is a disease.
And the book describes this terrifying period where a woman feels pain, sees her body changing, but has no name for it. And they mention patients often change doctors multiple times.
It's the classic diagnostic odyssey. You go to a GP, they say eat less, move more. You go to a vein specialist, they say your veins look fine.
You go to an endocrinologist,
right.
They check your thyroid, it's normal.
Right. And all the while, your legs are getting heavier, the pain is increasing, and you feel like you're losing your mind.
The authors actually call it the psychological burden.
They do. It's the fear of rapid, unstoppable progression. Imagine feeling like your body is a runaway train and every expert you talk to tells you there is no train.
That gaslighting aspect is just brutal. And the book is very open about the fact that this affects self-esteem. They don't shy away from the aesthetic component. They make it clear that caring about how your legs look isn't vanity. It's about recognizing your own self in the mirror.
Right. It's about identity. So the mission of this deep dive, and it mirrors the book's mission, is to unpack the systematic illumination of lipedema.
Systematic illumination, I like that.
The authors state clearly that there is a general lack of information, and here is where it gets really interesting. They aren't just blaming the public. They say this lack of information exists even among physicians.
That was a jaw-drop moment for me in the rationale section.
We do.
Usually medical texts circle the wagons, they protect the profession. But these guys come right out and say the poor transfer of knowledge starts with the doctors.
It is a moment of profound professional humility.
It really is.
They describe the origin story of the book. They were at these yearly meetings on lymphatic and lipedema surgery, surrounded by experts. And they realized that outside of that little bubble, most doctors had never even heard of lipedema, or even worse, they couldn't distinguish it from lymphedema.
We are definitely going to spend a lot of time on that distinction later, lipedema versus lymphedema.
We have to.
because the book treats it as the holy grail of diagnosis. But I love how they describe the result of this ignorance for the patient. They call it a chaotic, uncontrolled input of unknown information.
Which is the perfect description of the internet age, right?
Dr. Google.
Dr. Google. If your doctor doesn't know, you go online. And what do you find?
Miracle cures, horror stories, supplements.
Conflicting advice, everything. It's chaos. And the authors want to replace that chaos with structure. They say their goal is to turn the doctor's visit into a walk in the park.
A walk in the park. That is a high bar.
It is. But the idea is that if the patient reads this book, they walk into the consultation knowing the terminology, knowing the treatment path, knowing the risks.
So they aren't passive anymore.
They're empowered.
Before we get into the biology, I have to bring up one specific design choice they made.
Okay.
It's about the visuals. The book contains no before and after pictures of operations.
I found that fascinating. Absolutely fascinating.
It's so counterintuitive, right? If you go to any plastic surgeon's website, what's the first thing you see?
Before and after. Look at this transformation.
Look at these skinny legs.
Exactly. It's the primary marketing tool. And that is precisely why these authors banned it from the book.
So what was their reasoning?
They explicitly state they want to avoid the impression of advertising for surgical measures.
That says so much about their ethical stance.
It really does. It frames the surgery as a medical necessity, not a cosmetic upgrade.
I see.
If they showed amazing after photos, a vulnerable patient might read the book and think, I just need to buy this surgery and I'll look like a supermodel.
But by using 3D illustrations instead.
By using illustrations, they keep the focus on anatomy, on pathology, on the disease itself. They are prioritizing medical neutrality over the wow factor.
It tells me they really respect the intelligence of the reader.
Absolutely.
Okay, so we know the mission, we know the ethical framework. Let's talk about the guides. Who are these people?
The dream team.
Because looking at the bios, this isn't just a random assortment of doctors. It feels like a very specific squad.
It is a multidisciplinary dream team. And honestly, analyzing who is in the book tells us almost as much about the disease as the text itself.
How so?
You can't just have one type of doctor for lipedema. You need a convergence of different specialties.
Okay, so let's run down the roster. First, Dr. Zahir Jandali.
He's the anchor. He's based at the Evangelical Hospital in Oldenburg, Germany. His bio notes he's been focused on lipedema since 2007.
2007. That might not sound like ancient history, but...
In the world of lipedema research, that's the Stone Age.
Wow.
He has been in the trenches while most doctors didn't even believe the disease existed. He's developed unique surgical techniques, so he represents the specialized plastic surgery aspect.
Okay. Then we have Dr. Lucian Jiga.
The microsurgeon, also in Oldenburg. His expertise is listed as preserving extremities and vascular surgery.
Preserving extremities. That sounds high stakes.
It is. Think about it. Lipedema surgery involves aggressive removal of tissue from the legs or arms. These limbs are packed with nerves, veins, lymphatic channels.
A lot of important stuff.
A lot of important stuff. If you go in there with a heavy hand, you can cause permanent damage. You can destroy the lymphatic system.
Oh.
So having a microsurgeon involved signals that they prioritize the safety of the underlying plumbing. It's not just about taking the fat out. It's about leaving the structure intact.
And speaking of plumbing, that brings us to Dr. Corrado Campisi from Italy.
Yes. This is the heavyweight champion of lymphology.
A big deal in that world.
He's an executive committee member of the International Society of Lymphology. His inclusion is a massive signal, it tells us. You cannot understand lipedema if you don't understand the lymphatic system.
They're intertwined.
They are neighbors, they interact, and if you screw up one, you can destroy the other.
Okay. Then there's Dr. Ralph Weiss. He's listed as a visceral surgeon and an obesity specialist.
And this is the other side of the coin. If Campisi is there to say, don't forget the lymphatics, Weiss is there to say, don't forget the metabolism.
Got it.
He heads an obesity center. His presence acknowledges the elephant in the room. Many lipedema patients also struggle with obesity, but they are distinct things.
Crucially distinct.
You need someone who knows the difference between metabolic fat and lipedema fat to guide the treatment.
And finally, Angel Pecorelli Caposi, who brings in the aesthetic perspective.
Right.
So we have plastic surgery, microsurgery, lymphology, obesity medicine, and aesthetics.
It's a holistic approach. If you remove any one of those chairs from the table, the patient falls through the cracks.
Okay, let's get into the meat of it. Let's open the book to chapter 1. They title it simply The Lipedema.
Mm-hmm.
But right away, they start dismantling the idea that this is just fat.
That is the biggest misconception they are fighting. It's just fat, just eat less.
But it's not.
It's not. The authors break it down into very specific biological mechanisms. Section 1.2.3 is titled Hormone Activity of the Adipose Tissue,
which suggests the fat is alive, or at least reactive.
Reactive is the perfect word. Adipose tissue isn't just storage space like a backpack. It's an endocrine organ.
It secretes things.
It secretes things. It responds to things. The fact that they focus on hormone activity validates what patients have been saying for decades.
This started when I hit puberty.
Exactly. Or this exploded when I got pregnant. Or menopause made it worse.
So the tissue is listening.
The tissue is listening to the body's hormonal signals, estrogen specifically, and reacting aggressively.
And the way it reacts is interesting. They distinguish between lipohypertrophy and uncontrolled fat tissue proliferation.
Okay, this is a crucial biological distinction.
Break it down for us.
Hypertrophy means the existing fat cells are getting bigger, like balloons inflating.
Okay.
Proliferation means the cells are actually multiplying, making new balloons.
Ah, I see.
Normal weight gain in adults is usually hypertrophy. Lipedema seems to involve proliferation. The body is recruiting new fat cells in these specific areas.
And that's why diet often fails to shrink them.
Precisely. You can shrink a cell, but it's hard to diet away a cell that shouldn't be there in the first place.
And then there's section 1.2.5, Theory of Microvascular Disruption. That sounded a bit scary to me. What does that mean?
It implies that the tiny blood vessels, the capillaries within this fat tissue, are fragile or damaged.
How so?
Think of a garden hose that's old and porous. It leaks.
Okay.
In lipedema, these microvessels are leaky.
Is that why patients bruise so easily?
Exactly. That is one of the classic diagnostic signs. A patient will say, I bumped into the coffee table lightly, and I have a massive purple bruise.
Or I have bruises and I don't even remember hitting anything.
Yes.
Okay.
That's microvascular fragility. But it also contributes to the pain.
Oh.
If you have fluid leaking into the tissue where it doesn't belong, it creates pressure. It causes inflammation. That heavy leg feeling isn't just the weight of the fat.
It's the fluid.
It's the edema, the fluid sitting in the tissue.
Which leads right to the fear of progression. Section 1.5 is titled A Chronic Progressive Course, with a big question mark at the end.
That question mark is doing a lot of heavy lifting.
It is. It directly addresses that patient fear we talked about in the intro. The fear that they are doomed to just get bigger and bigger until they can't move.
Right. And by phrasing it as a question, the authors are introducing nuance.
So it's not inevitable.
Yeah. For a long time, the narrative was, lipedema is progressive, period. You will go from stage 1 to stage 4 inevitably.
Maybe not.
The authors are suggesting that might not be true for everyone. There might be stages where it stabilizes. There might be triggers that cause progression like extreme weight gain or hormonal shifts that can be managed.
It offers a sliver of hope.
A sliver of hope that biology isn't necessarily destiny if you have the right management plan.
Now, we can't talk about diagnosis without talking about the great mimics.
Oh, yeah.
The book spends a massive amount of real estate on this. Section 1.6 is obesity and lipedema. But then, chapter 2, the entire second chapter, is dedicated to the lymphedema.
It is a bold structural choice, right?
It really is.
You buy a book on lipedema, and the second chapter is about a completely different disease, but it is necessary.
Because of what they said in the rationale.
Yes. That poor transfer of knowledge means doctors just can't tell them apart.
Okay, so let's role play the doctor for a second. How do they distinguish them? Let's start with obesity versus lipedema.
The primary difference is proportionality.
We talked about that.
Obesity usually affects the whole body, face, trunk, hands, feet. Lipedema spares the extremities.
Spares the feet and hands.
You see women with very large legs, but their feet are completely normal. There is often a cuff at the ankle where the fat just stops.
What else?
Also, obesity responds to caloric deficit. If you starve, you lose weight. With lipedema, patients often report losing weight in their face and upper body until they look emaciated, but their legs don't change size.
That metabolic disconnect.
That metabolic disconnect is key.
Okay. And then lymphedema. That's about fluid, right? Not fat.
Correct. Lymphedema is a failure of the drainage system. It's fluid buildup because the lymph nodes or vessels are blocked or damaged. The classic sign there is the Stemmer's sign.
What's that?
You try to pinch the skin at the base of the second toe.
Okay.
If you can pinch it and lift it, it's negative. If the skin is so thick and swollen you can't lift it, That's a positive stemmer sign, and it points to lymphedema.
And in pure lipedema.
In pure lipedema, the feet are unaffected, so the sign is negative.
But the book also discusses how they can overlap.
Yes, lymphedema. This is critical. If the lipedema fat grows enough, it can physically crush the lymphatic vessels, causing lymphedema secondary to the fat.
Wow.
That's why Chapter 2 is so important. Section 2.7, Similarities and Differences, is basically the Rosetta Stone of the book.
So if you treat it wrong.
If you treat lipedema with pure fluid reduction techniques, like for lymphedema, you might help the swelling, but the fat stays. If you treat lymphedema with aggressive liposuction without prepping the lymphatics, you could cause a disaster.
So accurate diagnosis is the firewall.
Absolutely.
You have to pass through that before you can even talk treatment. Which brings us to Chapter 3, Treatment of Lipedema. And again, the authors surprise us. They don't start with surgery.
No, they don't. And for a book written by surgeons, that is significant. They outline a hierarchy.
Section 3.2 is Measures for Weight Stabilization. That comes before everything else.
I can hear the listeners groaning. Oh no, not weight loss again.
Right.
But the authors aren't saying lose weight to cure lipedema. They are saying stabilize the system.
What does that mean?
If a patient is in a state of rapid metabolic weight gain, surgery is dangerous. The inflammation is too high. The risk of complications skyrockets.
And they even mention surgical measures for weight stabilization, meaning bariatric surgery.
They do.
That seems controversial. Bariatric surgery for lipedema.
It is. But the logic is this. If you have a patient who is 300 pounds, and maybe 100 pounds of that is lipedema, but 100 pounds is metabolic obesity, you need to address the metabolic part first.
I see.
Bariatric surgery can reset the metabolism, reduce the systemic inflammation, and kind of reveal the true lipedema tissue.
It clears the fog.
It clears the fog so the surgeon can see what they're actually treating.
Okay, so get the weight stable. Then Section 3.3 is Complex Physical Therapy.
Often called CDT, or complex decongestive therapy.
What's that involve?
This is the standard of care for lymphatic issues, but they apply it here too. Manual lymphatic drainage, which is a specific type of massage compression garments, skincare, exercise.
But wait, if it's fat, why does massage help?
Because of that microvascular disruption we talked about, the tissue is wet, it's full of inflammatory fluid.
Wow.
The therapy wrings out the sponge, so to speak. It reduces the pain, reduces the swelling, and makes the tissue softer. The authors are very clear. You optimize the tissue environment before you cut.
And then finally, at Section 3.4, we get complex surgical treatment, specifically Section 3.6, the liposuction.
The main event.
But they don't just say liposuction. They break it down into techniques and shapes and liposuction volume.
And this is where the technical expertise of Jandali and Giga comes in. Techniques matters because you can't use the same aggressive suction you use for cosmetic body sculpting.
What?
You need techniques that spare the lymphatics. They likely discuss things like water jet-assisted liposuction or Wall-L or tumescent techniques where you flood the area with fluid to gently separate the fat cells from the nerves and vessels.
And shapes. What does that mean?
It's not just about making the leg smaller, it's about restoring function.
Oh, right.
If you have a massive fat pad on the inside of the knee, it alters your gait. It destroys your knee joints. The surgeon has to sculpt the leg so the patient can walk normally again. It's functional geometry.
I was struck by the section on liposuction volume, Section 3.6.3.
A huge safety topic.
Really?
There is a limit to how much fat you can remove in one surgery. If you take too much, say more than 5 to 7 liters, you risk major fluid shifts in the body.
The patient can go into shock.
Absolutely. You lose electrolytes, hemoglobin. The authors are emphasizing that this is a marathon, not a sprint.
So you might need multiple surgeries.
You might need 3, 4, or 5 surgeries to clear the legs safely.
Which leads right to Section 3.7.5, Consequences and Risks. They are not sugarcoating this.
No. Infection, bleeding, irregularities, numbness, and the specific risk of damaging the lymphatic system.
Which could leave the patient with permanent lymphedema.
Trading one disease for another. That's why finding the right doctor, which is in Chapter 5, is so critical. You need someone who knows how to dodge those vessels.
There was one section in the treatment chapter that felt like a total curveball. Section 3.A, Autologous Fat Grafting.
I stopped reading for a second when I saw that.
Me too.
Autologous fat grafting means taking fat from one part of the body and injecting it somewhere else. Usually you take it from the belly and put it in the breasts or face.
Isn't the whole premise of this book that lipedema fat is diseased? that it's inflammatory, that it has weird hormone receptors.
Mm-hmm.
Why on earth would you take bad fat and put it somewhere else?
That is the million-dollar question. It is highly controversial.
So why would they even include it?
There are, I think, two schools of thought. One is that if you move the fat to a healthy environment, say a breast, it might behave differently because the local signaling is different. The other possibility is that they are suggesting using healthy fat, if there is any, from a non-lipedema area to reconstruct defects caused by the lipedema surgery. But frankly, it's a risky proposition.
Because the disease could just start in the new place?
If that fat proliferates in the new location, you could theoretically transplant the disease. The fact that they include it suggests they're open to all possibilities, but I would want to read the fine print on that chapter very carefully.
It definitely highlights that we are still learning so much about the biology of this tissue.
No question.
Now, speaking of reconstruction, Chapter 4, body contouring surgery after extensive liposuction and weight loss.
This is the chapter that no one wants to talk about, but everyone deals with.
Right, so you have a patient who has had massive legs for 20 years. The skin has been stretched to the limit. Then you go in and suck out 10 liters of fat. What happens to the skin?
It doesn't just snap back like a rubber band.
So
it's been damaged. It loses elasticity, so it hangs. You can be left with empty sacks of skin on the thighs or arms.
Which can be just as debilitating in a different way as the fat was.
Absolutely. It can rub, chafe, cause fungal infections in the folds.
Yeah.
And psychologically,
Devastating.
Imagine going through the pain and cost of liposuction, hoping to finally see your legs, and instead you see drapes of loose skin.
So the authors detail specific lift procedures: thigh lift, upper arm lift, buttock lift, and section 4.7, tightening of the lower torso wall.
A thigh lift is a major operation. You are removing a long strip of skin and stitching it back together. It leaves a long scar, usually from the groin down to the knee.
So there's a trade-off.
The authors are presenting a trade-off. You trade the volume and the weight for a scar.
It really emphasizes that treating lipedema is a journey. It is not one surgery and you're done.
Not at all. It involves deconstructing the diseased tissue and then reconstructing the body's form.
And the timing matters.
Notice the timing. They put this in chapter 4, after the liposuction chapter. You can't do the lift at the same time as the debulking.
The body can't handle it.
The blood supply can't handle it. You have to remove the fat, let the body heal for months or even a year, and then come back to tighten the skin.
We are talking about a 2 or 3 year process for many women.
A massive commitment. Physical, emotional, and financial.
Which brings us to section 3.9, back in the treatment chapter, cost absorption.
The practical reality. This is a German book, so it references the German insurance battles, but the struggle is universal.
Lipedema is frequently classified as cosmetic by insurers.
Yep. They say, it's just fat suction, we don't pay for that.
Which is infuriating given everything we just discussed about the pain and mobility and vascular issues.
It is the definition of injustice. By including a section on cost, the authors are validating the financial toxicity of this disease.
Right.
Patients often have to pay tens of thousands of dollars out of pocket or spend years suing their insurance companies. The Practical Guidebook is acknowledging that the fight happens in the courtroom as well as the operating room.
So we have the diagnosis, the conservative therapy, the hierarchy of surgery, the reconstruction, the financial fight. That is an overwhelming amount of information for a patient to manage.
It's a lot.
Which brings us to the final chapter, Chapter 5, additional information about treatment.
It sounds like a boring appendix title.
It does.
But looking at the subheadings, it feels more like how to survive the medical system.
Yes. Section 5.2 is how to find the right doctor.
Given what we said at the start, that many doctors don't even know what this is, this might be the most valuable page in the whole book.
How do you vet a surgeon?
Exactly. Do they know about lymphatics? Do they do high-volume work? Do they have a plan for complications? These are the questions to ask.
And Section 5.3, presentation to the plastic surgeon. It sounds like they are coaching the patient on how to pitch their case.
They are. They are telling the listener, here is the language you need to use.
Don't just say, I hate my fat legs.
Right. Say, I have disproportionate pain, bruising, and mobility issues. Don't say, I want to look better. Say, I want to prevent progression and joint damage.
It connects back to the rationale stopping the chaotic input.
Yeah.
They want the patient to walk in with the vocabulary of a peer, not a supplicant.
It shifts the power dynamic.
Completely.
Instead of, "Doctor, please help me, I don't know what's wrong," it becomes, "Doctor, I suspect I have stage 2 lipedema, I have failed conservative therapy, and I am here to discuss surgical debulking."
That commands respect.
It does. It empowers the patient to be the CEO of their own body.
So let's zoom out. We've been deep in the weeds of biology and surgery. What is the big picture here?
I think the big picture is that Lipedema, a practical guidebook, is an artifact of a medical system in transition. It is trying to fill a massive void of empathy and information.
We've learned that lipedema is not a lifestyle failure.
No, it's a complex disease with hormonal triggers and vascular damage.
We've learned that diagnosis is tricky but possible if you know what to look for. The stemmer sign, the disproportion, the bruising.
And we've seen that treatment is a ladder. Stabilization first, then therapy, then specialized surgery, then reconstruction.
And we've acknowledged that the goal isn't perfection, it's relief.
It's about stopping the pain and giving the patient their life back.
But I want to leave our listeners with a thought that struck me while reading the rationale section again. It's something of a bitter pill.
Okay, what's that?
The authors, these world-class experts, admit that they do a lot of scientific projects in lymphatic surgery. Millions of dollars in research, huge studies.
Right.
But they admit they do quite little to nothing in the field of lipedema research.
Even though, as they say, lipedema accounts for a much larger share in our clinical routine.
That's it. That is the provocative thought to end on. If this disease is so common, if it makes up the bulk of what these surgeons see every day, why is the research lagging so far behind?
Yeah.
Why do we have detailed maps of rare lymphatic diseases, but we are still writing the introductory guidebook for lipedema in 2022?
It really forces us to question how we prioritize women's pain and complex tissue diseases in the medical research establishment.
Is it because it looks like fat? Is it because it affects mostly women?
I think all of the above. The bias is baked into the funding models.
This book is a massive step forward. It's a beacon. But the gap, the authors describe, it is still vast.
It's so vast.
And it is going to take more than one guidebook to close it. It's going to take patients, doctors, and researchers demanding that this common disease gets the attention it deserves.
A sobering but important place to leave it.
For anyone listening who recognize themselves in the adventurous search we described, just knowing the map exists is the first step.
You aren't crazy.
You aren't crazy and you aren't alone. Thanks for diving in with us.
Thank you.